All right. Thank you all for being here this morning. I really appreciate you all tuning in and for another modified fourth Friday, second Friday coronavirus update. We're joined by our UCH EMS team this morning. So my name is Angela Wright. I'm one of the EMS physicians at the University of Colorado Anschutz Hospital. Danny Wilner is joining us this morning as well. Desmond McNeil, who's our EMS a guru everything, and Mark Schuschel, who's our new EMS director. Go ahead and see if I can get my slides to work here. So before we get started on the nuts and bolts of our EMS COVID-19 update, I'm going to let Mark say a few words. We're going to start out our update this morning by updating the story about the tiger that has coronavirus. Mark, you want to give us an update on the tiger?
Sure. First off, thanks everybody for getting on the call, and we hope this is useful to everybody as we walk forward through this COVID-19 response, and hopefully it's helpful. I want to thank Dr. Wright and Dr. Wilner for all the work that they've put in on this. You can imagine their clinical schedules as well as keeping the EMS folks on our side of things running has been a real challenge, and a lot of late nights and early mornings. So thank you to both of them for all the work they're doing. The tiger thing came up, and we did a quick open source media review of what is out there, and there is actually some peer-reviewed information on it as well. But the nuts and bolts of it were Nadia is a 4-year-old female tiger that is in the Bronx Zoo. And a couple of weeks ago, she actually came down with similar signs and symptoms of human COVID-19 patients that are positive. So my biggest question is, how do you swab a tiger? And it turns out you use a little bit of ketamine and 6 veterinarians and a special swab designed just for large exotic cats. So they got that done, and she actually wound up being positive for COVID-19. That's got most of the research world a little bit puzzled, because as you know, the theory is COVID-19 started in the Wuhan area through a wet market where they sell exotic and wild animals for consumption. The theory, which hasn't been proved yet, is that it may have come from a bat that was consumed by human, which transferred the virus from the bat population into the human population. The baffling point is that for it to go into a third type of animal is fairly rare, and that started quite a bit of research on the human to different domestic or wild animal reservoirs. So they know that there are about 200 different kind of coronaviruses that can be found in 1,000 different species of bats. So certainly they do cross over into different species of bats quite frequently. And it's confirmed that Nadia, the tiger, has been infected. She is expected to make a full recovery and is doing quite well with just supportive care. So that point has led researchers to start looking at, can COVID-19 cross into domestic animals and then have them become another vector to increase the human population that gets infected with it. A lot of that research is ongoing. There's certainly theories out there that it can cross over into domesticated cats in particular, and they're looking into that, but I have not done a deep dive into that literature to find out what they found yet. So it's a concern. It's something to think about. And if we continue these, I'll follow up with the domestic wildlife and exotic cat Tiger King portion of the COVID-19 update. So that's it. Back to Dr. Wright.
Thank you, Mark. Appreciate the domestic and wildlife update there. We're going to get started this morning. We're going to do a quick review over the coronavirus, and this will get shorter and shorter as we continue to do these. We're going to do a review of the numbers at a glance, both on the global, the national, and the state level. We are going to talk today a little bit about treatments and some of the literature that's out there. We're going to talk about testing, and we're going to talk at the end a little bit about crisis standards of care, what that means, what it implies for the EMS community, and a little bit of the concepts there. Feel free to ask questions throughout via the chat mechanism. As we mentioned, Dr. Wilner will be monitoring the chat. We'll probably try to do most of them at the end. But Dr. Wilner, please interrupt me or jump in if there's a question that you feel would be definitely better answered in the middle of the presentation. I'd like to be as helpful as I can to our community that's tuning in today. So we know this is a novel coronavirus. SARS-CoV-2 is the name of the coronavirus. It causes a disease called COVID-19. This is typically a lower respiratory tract infection, although the upper respiratory tract and GI tracts have also been documented as symptoms and as an infection portion of the COVID-19 disease. Most people have mild respiratory symptoms, upper and lower, and recover without an issue. But some people have an ARDS-like response and profound hypoxia. So just to touch on that for a second, this is a chest x-ray. This is a normal chest x-ray of an individual. You can see there that the dark on either side is where air is. You can see the ribs. The blob in the middle is the cardiac silhouette, and it's nice and dark on either side, indicating that the lungs are filled with air and nothing else. The little bit of haziness around either side of the heart border is blood vessels and other structures in the hilum and mediastinum. This is a chest x-ray of a patient with ARDS, and it's the ARDS response that we're seeing that's causing the severe respiratory consequences of the COVID-19 infection or the SARS-CoV-2 infection. So what you notice between these, the biggest differences between these two chest x-rays is the chest x-ray that you're viewing now has a lot of white, what looks kind of like fluffy, patchy infiltrates, and that's essentially fluid that's filling the alveolar space. And the fluid filling the alveolar space causes that change in the way that the chest x-ray looks. You can also see there's some additional lines and tubes. This patient's intubated and ventilated. And as you can imagine, if your lungs are supposed to look like this and now they look like this, oxygen exchange at the cellular level is going to be much, much more challenging. And so this is what's causing what we think the profound hypoxia in these patients. The fact that the oxygen delivery mechanism is disrupted by fluid and changes at the alveolar level that are making it much harder for the patient to oxygenate. There's a lot of other research and data going on around there about compliance and the flexibility of the lungs and the differences between this infection and the typical ARDS, and whether this is a hemoglobin level problem or something that has more to do with the actual lung function, and all of that's still ongoing. But from where we're at now, as you can see, this is a reason why so many patients require such high levels of oxygen care. And if your lungs end up like this, more likely than not, you're going to be on a ventilator. So this is what the infection is causing right now. And then as far as the spread of the novel coronavirus, it's droplet and spread primarily. Those droplets can land on surfaces, which makes it contact. And then, of course, there's always the concern for airborne spread and whether or not these particles hang around in the air, especially after aerosol generating procedures, which seems to worsen and increase the transmission from more of an airborne mechanism. So let's talk a little bit about the numbers. Again, this is always rapidly evolving. I try to get the situation reports the night before I do these presentations so that I can get you all the most up-to-date information. The slide with the numbers with the X through it are from the last time we did one of these updates. So the last time we did one of these updates, as you can see, there are about 500,000 cases reported globally. And then as of last night, there's about 1.5 million cases reported globally. Again, some of this is going to be limited by testing and reporting. We're really relying on countries to have adequate testing mechanisms and also relying on countries to report their data in order to get accurate numbers. But you can see here we've had about 85,000 deaths worldwide. And this is in the United States. This is from the CDC, about 427,000 cases that have been reported and almost 15,000 deaths that have been reported in the United States. And there's 55 jurisdictions that are reporting cases and that are giving us the numbers from across the country here. And then let's look a little bit at Colorado. So this is a case summary. These come out they update them 4 p.m. on the CDPHE website. I encourage you guys to go to both CDC, WHO, and CDPHE, which is where we're getting the most accurate information as far as the agencies that places are reporting their cases to. So in the state of Colorado, we've had 6,200 cases reported, and about 1,200 of those are hospitalized in 56 counties across the state. We've tested a lot of people. We've tested 31,000 people. And so far, we've had 226 deaths. In the last column there, the outbreaks are at residential and non-hospital healthcare facilities, such as SNFs and other places that people live together as a group. So there's some graphs to review here that I think are interesting and worth having a little discussion over. So this is these are the cases of COVID-19 in Colorado by reported date of illness. So remember, again, this relies on testing, and you can see kind of here in mid-March is when we started ramping up our testing. So you have to remember that some of the increased number of cases is the fact that we are detecting more of the cases. That being said, you can see that there is a gentle, not so gentle, upslope of the curve here as the number of reported cases has increased over time. And this is one of the biggest questions right now. Have we peaked in Colorado, and have we successfully flattened the curve? So this is the cumulative number of cases of COVID-19 in Colorado by the reported date of illness. So you can see that that graph is continuing to increase. It's continuing to go up. And you can basically see by the height of how much it changes day to day as far as the number of cases that have been reported in Colorado. But this is what we talk about when we're talking about flattening the curve, and this is the number of hospitalized cases of COVID-19 in Colorado. So that first graph involves people that were tested, and many people that were testing and diagnosing as positive, we're still sending home because, as I mentioned, most people do just fine. So we're sending them home, telling them to quarantine and self-isolate for at least 14 days. And then we have kind of strict return to work features that people have to meet in order to come back to work or to return to their jobs. But the number of hospitalized cases is part of why flattening the curve is so important. And we'll get into this a little bit later when we talk about crisis standards of care, but the hospitalized cases is what's going to really strain our EMS system, our hospital system, our ventilators. And so this is the curve that's really important to look at as well. And you can see when you look at this curve, initially, when you kind of look down at the March 27th there, the steps, the incremental steps are pretty high. And then coming around the corner into April here, those steps are getting smaller and smaller. And if you look at this graph on the CDPHE website and you hover over each of those bars, it tells you how many cases were added on from the day prior. And in the end of March, you can see many more cases each day as that step is bigger. But here towards the beginning of April, those steps are getting smaller, which would indicate that we're adding fewer and fewer people to this cumulative number each day, which is promising, but it certainly does not mean we are in any way, shape, or form out of the woods. So it seems that the social distancing is working. The stay-at-home orders are working, but we are still increasing. If you look at that first graph and you look here, we're still going up. We are going on the right direction as far as the slope, but we're still in the midst of it here. We're going to talk a little bit about treatment here. This has been very, very popular in the press and on social media as far as how we're treating COVID-19. There is no known cure, there is no known treatment, and there is no vaccine as of this point. But hydroxychloroquine and chloroquine are perhaps some of the most chatted about treatments that we're seeing. So this all seemed to start from a small study in France. There were some studies done in Wuhan as well. But there was a small study in France that was published about the use of these in COVID-19. And hydroxychloroquine and chloroquine have been shown in the test tube to potentially kill the virus. But in actual real life and in people, the data is much more inconsistent and unreliable. But this small study looked at whether or not there was a decrease in the viral load and an improvement in outcomes for patients that were treated. And as we know, since this is a novel coronavirus, our data and our research is very, very limited by small numbers, and we're still trying to figure this out as we go. But the study was published and it kind of started a big movement if we should be treating all of these patients with these medications. As of right now, oh, I need to speak. Oh, sorry, I'm just getting a little note. I need to speak louder. Is this better? Can you guys hear me better now? Hopefully. I will try to speak up a little bit. So the hydroxychloroquine and chloroquine, as of right now, is the first line in hospital treatment. So it's actually the first line treatment that we're using for patients that are in the hospital. And of course, we're studying outcomes and trying to evaluate if this is making any difference. How does it work? It blocks the synthesis of DNA and RNA, but the exact mechanism is unknown. As I mentioned in the last update, these are used traditionally as anti-malarials and as prophylactic medications for that, but we don't know exactly how these medications work. The thing that we do know very, very well with hydroxychloroquine and chloroquine is that they have a very well-known toxic profile. We do know that these drugs are not in any way, shape, or form benign. They cause cardiac dysfunction, arrhythmias, metabolic derangements, and potentially intractable seizures. And so it's very important when we start talking about treatments that we are balancing what we do know, which is the potential adverse reactions to these medications, with what we don't know, which is whether or not this makes any clinical difference or improvement in patients that have COVID-19. So the difference here is trying to figure out the data that we can extrapolate from very small number of studies and balance that with what we do know, which is potentially adverse reactions. So this is from the infectious disease department at the University of Colorado Hospital, and it shows that we are using hydroxychloroquine to treat this disease. It's a pregnancy category C. Again, the studies from the pregnancy categories are from malarial data. It does not actually have anything to do with COVID-19 data. And you have to use caution in liver disease. And you have to monitor the QTc in these patients. It can cause visual changes, neuropathy, and cytopenias. And azithromycin is another thing we're going to talk about in just a few minutes, but it does seem to have additive adverse effects when it's combined with hydroxychloroquine, especially when you are considering the QTc interval. These are a few of the antivirals that are on most hospitals' treatment algorithms at this point, lopinavir and ritonavir. There's a small New England Journal study that was recently published in the middle of March and that looked at both of these in patients that were not in ICUs that were doing well, and it didn't seem to have much of an impact, but again, a very small study. And then this is another medication that we're trying in the hospital. It's probably worth a blurb here about hydroxychloroquine and chloroquine as a prophylactic medication for COVID-19. The interesting way that I kind of was thinking about this is we actually have patients with like rheumatoid arthritis that are on these medications at baseline, and the patients that are even on these medications at baseline are still getting COVID-19. So while that's not a study and it's more of just an anecdote and extrapolation of some logic, they're not going to work prophylactically. If we have patients that are on these all the time that are still getting the disease, that would suggest that it's not going to prevent anybody from getting the disease. So as of right now, it's not recommended. Azithromycin is another thing, and I mentioned it up here, that's been suggested to be used in concert with the hydroxychloroquine or chloroquine. Azithromycin is a macrolide antibiotic, so antibiotic meaning against bacterial infection, not so much against viral infection. As far as antibiotics go, it really does have a pretty good safety profile. And there's data that it possibly has some anti-inflammatory action in COPD patients, which is oftentimes why we give it there. But of course, none of this has been studied in COVID. And azithromycin is also notorious for prolonging the QTC interval. So if you're combining hydroxychloroquine, which has known cardiotoxicity and potentially dangerous outcomes, with an azithromycin, which is also known to prolong your QTC interval, you worry about this. You also worry about this in patients that have metabolic derangements and hypokalemia that you then put these medications on. And so it's something that is absolutely worth diving in deeper, and the medical community is constantly studying these things, but it's certainly not something that we would want to just start blindly prescribing to patients without data that it actually makes a difference, without it knowing their underlying health conditions, prolongation of the QTC, what other medications they are on, etc. So lots of work to still be done there, but those are the two most common discussed and talked about treatments at this time. There's ongoing studies through the NIH with monoclonal antibody therapy, and this is traditionally reserved for the patients that are very critical in the intensive care unit on a ventilator, trying to figure out if there is a way that we can decrease the amount of cytokine storm and inflammation that's occurring that's potentially leading to the severe ARDS. And those clinical trials are ongoing. There's a number of them ongoing at Anschutz right now. And then convalescent plasma, or that's the blood and plasma from folks that have had COVID-19 and have recovered, in theory, potentially should have antibodies and should be able to provide some sort of protection or treatment given their own immune response that they had when they had the disease. And as you can imagine, as we're learning as we go here, we're making up things as we go, as the convalescent plasma is something to be considered. It's something that's been done a few times in a compassionate care use, and it's something we will continue to look at. I believe, and Danny, speak up, or Mark or Desmond if this is incorrect, but right now I think the Children's is the kind of the lead site as far as getting blood donations from people that have recovered from COVID-19. And I think that they're the ones kind of organizing the blood drive in order to further look at the convalescent plasma and the potential antibodies and things that are going on.
That's correct. And I'll send out a link to the website where you can go on and review their information if you're interested in donating. I think the specific thing to emphasize there is at this time, they're only accepting people who had confirmed cases of COVID-19 through RT-PCR testing. So if you were symptomatic and think you had it, but didn't get tested, I don't believe they're accepting those patients at this time, although there is plans to start accepting those patients at some point in the future. Not sure that they have a specific date set up yet. But again, I'll send out that link on the chat and we'll send it out in the follow-up email.
Thank you. Speaking of testing, Dr. Wilner, that was a perfect transition. So how are we testing people? We're testing right now with a nasal swab that does an RT-PCR. And this is currently under study, but this is the information that we have from the University of Colorado system and the tests that we have done here. And what's interesting to look at here is that the testing accuracy is going to change depending on where you are in your disease course. And that's important to consider if you're considering, when you're considering testing people, if you're doing follow-up swabs, etc. So if you're testing people before symptoms start, if they've been exposed, but they're still in the incubation phase, you have a really wide range there, 25 to 75% positive. So could be pretty decent, but could also be fairly inconsistent if you have no symptoms of COVID-19. If it's 1 to 3 days after the onset of COVID-19 symptoms, that seems to be when we get the best test, which is 75 to 95% positive. So kind of in that initial window, when you first start having symptoms, that's when the test is the most reliable, arguably because that's when you're going to have the highest viral load. And then if you're testing people 7 to 14 days after the onset of symptoms, in patients that are gravely ill, so 7 to 14 days after the onset of symptoms, but potentially in the ICU, then we're looking at about 50% positive. And if you're minimally ill or you had mild symptoms to begin with, then about 30% positive in patients that are pushing that 2-week mark. So it really does matter when we're testing people. And again, this is just from the university data. This is from our lab and kind of what we've been telling people as far as how accurate our tests are. The second swabs as a test of cure is another question that comes up, and that's a tough one. You know, the question is, do you swab people again and see after they're done to make sure that they're no longer positive? And we're seeing that there's intermittent positivity during convalescence or during the recovery phase. So there's a chance that if you hit that, you will be able to see if somebody's negative, but there's also patients that intermittently pop up positive during that convalescent phase. And then what about false negatives? What about if your patient really you think has COVID and their test is negative? As you can see from the first bullet point, a lot of that depends on where they are in their course of illness as far as how reliable that testing is. But at the university system, we did 548 repeat tests on patients that had already been tested and were negative, and only 4 had a positive after the initial negative, or 1.5%. So that would indicate that it's a fairly reliable test, but again, a lot of that really is determined by where they are in their disease course and potentially how high their viral load may be. So we're going to go on now for a second, and we're going to talk a little bit about crisis standards of care. What are crisis standards of care, and what do we need to know as frontline healthcare providers? So crisis standards of care are designed to help healthcare professionals in making really tough decisions, making decisions that maximize patient survival and minimize adverse outcomes. Basically, in the event that the system is overloaded, you have more patients than you have resources, and so your normal standards of care are no longer possible because you do not have the appropriate resources to complete your normal standards of care. And that's the concept of crisis standards of care. It's a utilitarianism concept from a philosophical standpoint, which is providing the greatest good to the greatest number of patients. So what is the best way to use the limited resources that we do have to impact the greatest number of people? And it's the allocation of scarce resources to optimize outcome for triage and treatment. So these are the tough decisions. This is a very scary place to be as a healthcare system, and I think it's worth discussing. I don't know if we'll get to this point, but I think it's worth understanding as frontline healthcare providers what this means. So there's different ways that you can implement crisis standards of care, and there's different groups that will need to implement crisis standards of care. So hospitals is what we think of when we think of crisis standards of care, and let's say the limited number of ventilators. And how are you going to determine who gets put on a ventilator, who gets removed from a ventilator when you only have so many? But crisis standards of care absolutely apply to EMS systems. When you have 10 ambulances and you have 45 calls in the queue, how are you going to designate the resources that you have? How are you going to screen and try to figure out how to get the greatest good to the greatest amount of people? And then PPE is another sub area which can implement crisis standards of care. And essentially the way to think about that is how you can justify using different, not necessarily, quote, approved levels of PPE to try to protect healthcare providers and the ways that we can protect ourselves and protect our patients. So there's different channels for which crisis standards of care apply. Crisis standards of care are a very collaborative set of standards that are put together by a large committee or a group of people that often includes physicians, nurses, and ethics specialists, behavioral health specialists, and legal personnel. And they're activated by the government, whether that's local, state, or national. And it's done in a state of emergency or a state of a pandemic if it's determined to be needed. And essentially, it provides some legal protection for alternative care that may occur when demand outweighs supply. But the other thing that it does is it provides some guidelines for healthcare providers, and it really tries to standardize some of these decisions so that it's not on the onus of each individual provider to try to make these extremely challenging decisions. And so it's a way to try to provide some guidelines and some guidance to our providers in a more standardized way if we get to the point that we're trying to minimize the amount of resource utilization and maximize the amount of patient care. So when do you need crisis standards of care? You need crisis standards of care when your staff, your supplies, your infrastructure, or other vital resources are unavailable or undeliverable to healthcare facilities. Or you also need them when other healthcare systems have a similar unmet needs. And so this is important because crisis standards of care is usually implemented and applied when there's a large region of people that are all affected. Because if it were just one hospital, arguably you could implement mutual aid and other mechanisms by which to share within a geographic area. However, when all geographic areas are hit, that's when you start to see crisis standards of care needing to come into play. And again, similarly, when the patient transfer is not possible or feasible. So if you're working at a hospital or for a system that doesn't have the resources that a particular patient or group of patients need, in theory, you'd like to be able to transfer that patient to the care that they would need. However, if transfer isn't possible, then you may need to implement the crisis standards of care. Additional indications is when the access to medical countermeasures is likely to be limited and not sufficient to meet expected demands. And again, when the available local, regional, state, and federal resource caches have been distributed and no short-term supply restock is foreseeable. And again, that's going to be especially applicable to PPE as we go forward with this pandemic. And then if there's multiple healthcare access points within a community or region that are impacted. So if it's not just EMS, but it's EMS and hospitals and primary care physician offices and virtual health, if there's a bunch of different areas that patients would try to normally access the healthcare system that they can't get to. So here at UCH, so just to kind of close on the crisis standards of care here, this is all available on the CDPHE website. And as of recently, the crisis standards of care has been implemented and activated for both PPE and for EMS. And what this means is that we're getting backing by the government to make sure that we're safely implementing some of the changes that we've already made in the EMS community and some of the changes for PPE reuse, some of the patient standards for ongoing wear of an N95 past its shelf life, some of those kind of little otherwise nitpicky things, we're getting the support and the backing that we need at the government level to make sure that the things that we're doing are acceptable and that they're within these standards that have already been kind of set up and are ongoing and acknowledged by the government and by some of the legal community as well. So a few updates of the things we're doing here. Again, system and hospital-wide coordination through the UC Health groups. We are having ongoing discussions and planning for alternative care sites, and this falls into crisis standards of care, and that potentially EMS destinations to different care sites, to different places to take care of patients as opposed to the traditional emergency department. Ongoing conversations and meetings about that. We're continuing to promote and encourage and yell and stress and yell at people about ongoing social distancing and self-isolation, because as you remember from that curve, it seems to be working. And then again, a reminder to protect yourselves and not to rush into a room of a patient that is potentially crashing or dying without making sure that you're protecting yourself, because if you end up getting sick, then that is no good for anybody involved. I want to take a few minutes here. We'll get to questions and answers in just a second, but just to, again, thank all of you that are providing care, that are on the front lines, that are risking your own health and your family's health in order to provide care for your community. I think there's a lot of media and public interest in hospital workers and healthcare workers right now, but I want you all to know that you are also an essential part of this whole process and this whole system, and your work does not go unnoticed. We couldn't do anything that we do without the EMS community and your help and your willingness to make the sacrifices that you do each and every day in the pandemic or even not in a pandemic. And we see you, we appreciate you, and we thank every single one of you for the work that you're doing. We're all exhausted, we're all tired, and I think this is an exceptionally challenging time, but I truly believe that with everybody's hard work, we're going to get through this, and we're going to make it through together as a community and come out stronger because of it. So thank you to each and every one of you that's listening, and all of your friends and family that work in the healthcare world as well, and as our first responders. We really, really appreciate you. We'll go ahead and switch over to some questions and answers. And I'm going to mute myself and try to figure out how to pull up the chat, but Danny, maybe you can help with that too.
Absolutely. We've gotten a few questions from attendees already. If you have more questions, please put them in on the chat and we'll try to get to them. Angie, I'm going to take the first one just because I was able to do a little bit of a literature dive while you were talking, and it's a really good question. A couple people asked about vitamin and mineral supplements and what the evidence is for some of these agents, specifically vitamin A, vitamin C, vitamin D, and zinc, as well as quinine, which, if you know, is what they put in tonic water and what was traditionally one of the early anti-malarials. So what we can say about these vitamins and minerals is that there's some stuff we know and there's a lot that we don't. We know that having adequate levels of vitamins and minerals in your body is good for your overall health, but that hyper stimulating or taking additional levels or taking large quantities of some of these vitamins and minerals is not only unnecessary, but actually is potentially dangerous, especially for the what we call fat soluble ones that can actually stay in your body for a long time and cause problems in excess. So what I would say is for people who are at high risk for malnourishment, it's reasonable to take a vitamin supplement, but you don't need to go crazy. You don't need to take 5 vitamins rather than 1. And then specifically, do these vitamins and minerals have an effect in COVID-19? The honest answer is we don't know. We know that some of these, such as zinc, vitamin A, vitamin C, and vitamin D, when looked at large groups of respiratory viruses in general, may have some efficacy to reduce the severity or duration of infection, but that there's not good evidence for COVID-19 specifically that they have any effect. So any data that we have is basically extrapolated from prior studies looking at sort of general viral illness. Now, is that to say they don't work? No. Is that to say they do work? No. So I think the takeaway from that is if there's a person that we're concerned may have a vitamin or mineral deficiency, it's reasonable to treat them with a multivitamin. Most of us who are healthy adults probably have pretty good levels of these things in our body to begin with. So I don't think you need to run out and buy a super vitamin, but I don't think it's going to cause harm for you to take a daily multivitamin. Digging down a little bit more into the zinc question, zinc has some effect against viruses in the way they replicate. And so the theory is if you increase your zinc levels, again, it may have more antiviral activity. But again, there's very limited data for COVID-19 specifically, just because these viruses have only been out for such a short period of time. What I would emphasize is that the anecdotal information that we get from a single physician in a state or from a single paper that's poorly completed, meaning the study is very limited in terms of how it's done. It doesn't follow the scientific principles that we strive for when we're producing high quality studies. Those anecdotal studies and the one-off evidence, while they sometimes capture headlines and get a lot of attention from the media, really don't give us in the medical community any information that's helpful for treating these patients. The best way that we can create pathways for treatment is through well-controlled, well-studied, randomized trials where we enroll patients in those trials, and we have to wait weeks to sometimes months to actually look at that data and get a good sense of whether that intervention was effective or not. And when we do poorly controlled trials or hastily constructed things, while we may get information from them, that information is typically faulty or at high risk for being compromised. And we've seen this again and again, where an initial study shows promise, but then when there's a follow-up study that's done that's really high quality, it doesn't actually show any benefit. So the one line takeaway is, if there are vitamin deficiencies in people, or if you're interested in taking a multivitamin, I think it's safe and reasonable to try, although I'm not sure that it's going to dramatically decrease the risk of infection, the duration of infection, or the severity of infection. Turning to quinine real quickly, as I said, quinine is in tonic water. It was traditionally used as an antimalarial very early on, before we had developed additional pharmacologic agents such as chloroquine and hydroxychloroquine. And I think that connection, that malarial connection, is how people sort of extrapolated that since we're trying chloroquine and hydroxychloroquine, then quinine is something that we should use as well. Again, no evidence that we can see to date that I was able to find that quinine either prevents, ameliorates, or reduces the risk of infection. So again, with all these things, the one-offs sound really good and catchy, and when it sounds too good to be true, it probably is too good to be true. Let's take a second question. Angie, this one I'm going to kick to you. The question was, in the state of Colorado, how are we distributing patients with severe disease? Are they equally distributed throughout the hospitals? Are we actively moving them between the hospitals, or are patients sort of landing where they land and being treated where they're initially brought?
At this point, patients are sort of landing where they land and being treated where they are, assuming that where they land has the capacity to do so. I know that there is some transferring within health systems, so within UCH, different facilities that have different capabilities as far as ICUs, ventilators, oxygen needs, etc. There's occasionally some transfer, between the different UCH systems and between the Health One systems. I think each hospital at this point is kind of working to maximize their resources and delivery of care within their own system. As of right now, from what I understand, there's not a whole lot of shuffling of patients around from in between systems to try to distribute. Patients have been pretty well distributed throughout the Denver metro. That being said, the VA recently has opened their doors to any patients with, not from an EMS receiving standpoint, but from an interfacility transfer standpoint, to patients that are service connected, as a way to try to kind of help offload some of the other institutions. There's ongoing discussions within the Denver metro area. If this continues to grow and our case numbers continue to accelerate, if we need to come up with a system that will allow from a more even distribution of patients from the pre-hospital standpoint. That's not something we've implemented at this time, but it's something that we're drilling and something that we're coming up with a way to help to evenly distribute patients while still maintaining the integrity of our EMS systems and making sure that places are still working within their geographic area and not transporting all the way across town and then having to try to get back to their base or their station. And so we're working with all of the metro area PSAPs and the metro area medical directors to make sure that we have a system, should this continue to grow, that we can use to evenly distribute patients throughout the metro system. But at this time, we're doing okay having patients kind of settle themselves where they land.
Dr. Wright, this is Mark. On that note, there's also ongoing plans through the state to open a large alternate care facility in the central part of Denver at the convention center that can hold upwards, over 1,000 patients. They're actively planning on how to operationalize that as we speak. It's certainly not something that's open yet, but depending on what the charts look like and if we flatten the curve or not, those plans are being made as well. So if hospitals get into a situation where they are overrun and overwhelmed, transfer of patients with less critical need, whether they're COVID or not, into that alternate care facility. Those plans are being made. So if we happen to find ourselves in that situation, then we'll have additional beds that we can take patients to.
Okay, next question. First, we're just going to do a brief housekeeping reminder. If you're joining us by phone, or if you're joining as part of a group, meaning from a station house or something like that, and you weren't the person that logged in and entered your email address, please email Desmond McNeil, our EMS manager. His email is desmond.mcneil@uchealth.org. That'll allow us to, number one, know how many people are joining us, and number two, send you the follow-up link in order for you to get your EMS continuing education. So that's the only way we can get you the hour you get for sitting in with us and listening to this, is if you email us. Next question is going to be about the testing. So we know that some people have been having symptoms and have been tested and have tested negative. So Dr. Wright, can you speak to the test characteristics and whether there are other viruses that are circulating right now that can look like COVID, but that are not actually COVID in the community right now, that might sort of make someone think that they have the virus, but in fact that, they have something else?
Yeah, I could try. I think that the testing that we currently have for COVID is an RT-PCR, which is a sophisticated test to detect the actual SARS-CoV-2 virus. We have other ways to test similarly for other viruses that are out there and in the community, such as other coronaviruses or influenza or rhinovirus or human metapneumovirus. The RT-PCR test for COVID-19, for the SARS-CoV-2, is specific just for that virus, and that specific test is unique for the SARS-CoV-2. We have additional tests for the other viruses that are also done via the nasal swab, and a lot of those viruses do have very, very similar characteristics with lower respiratory symptoms, fevers, dry cough, etc. So there's a little bit of back and forth of whether we need to be testing everybody for the other viruses that this could be, and whether there's co-infection, and that's something that we're having ongoing discussion with. Now there's also testing, and there's a lot more out there right now that people are talking about antibody testing, and that would be a serum test to look at whether or not somebody has antibodies to SARS-CoV-2, and as a way to say, oh, maybe I already had it and I'm immune. The issue with those right now, though, is that especially there aren't any right now that are approved by the FDA, although that's probably just around the corner. But there are some from private corporations and private lab companies that are being advertised. And the concern with some of those is that if they're not specific enough to SARS-CoV-2, then they can actually test positive for the other coronaviruses. There's tons of other coronaviruses out there that structurally are very, very similar to SARS-CoV-2, just little tiny microscopic differences. And if you have antibodies to the other coronaviruses and your lab is not specific enough to the SARS-CoV-2, then it's going to look like you're immune when you actually potentially just were infected at some point in your life with another coronavirus, not SARS-CoV-2. So be wary and careful of the antibody tests that look at SARS-CoV-2 right now, because we're almost there, but we're just not there yet. And a lot of those other viruses can look very similar, both clinically and in the laboratory. So we have to make sure that we're testing and accurately identifying those. I don't know if that answers the question, Danny.
Yeah, I completely agree with what you said. I'll simply add on that when we look at the sensitivity and specificity of these tests, meaning how well they actually check for the virus and how accurate they are in finding this virus and not something else, we give us one number, but in reality, it's really a spectrum, and it's a spectrum based on where in each individual person's clinical course they are with this virus. Because what we know is that SARS-CoV-2 does sit in the nasopharynx, in the cells of the nasopharynx for a little while, but it's predominantly a lower respiratory infection, meaning it affects the lungs. And so what can happen is the body can actually clear that viral infection from the nasopharynx prior to it clearing it from the lungs. So patients could theoretically still be symptomatic from lung infection, but have a negative nasopharyngeal swab, is one sort of the false negatives that can happen. And then as Dr. Wright said, certainly the other is that they don't actually have SARS coronavirus, but instead they have one of the other 4 typically seasonal coronaviruses that are always in the environment, or one of the other 20 or so viruses that we test for on a full respiratory viral panel. So there are lots of reasons that you could get either a false negative or a true negative and have actually a second infection. And there was one study or one analysis out of California that looked and showed that about 20% of patients with COVID actually may have been co-infected with a second virus at the same time. So initially we were actually starting our workup with just a respiratory viral panel, and if we found influenza or enterovirus or human metapneumovirus, we didn't actually test for coronavirus. That was in early March, and we subsequently changed our testing algorithm because we found that there was a significant number of patients who were actually infected with both at the same time. And so we sometimes were probably stopping early and having early closure because we found a virus, but it may not have been the only virus that people were infected with. Next question is that we know that the coronavirus enters cells through the ACE2. And so the question is related to blood pressure and whether the coronavirus does anything specifically to blood pressure because of how it enters the cells. And then I'll tag on a second part of that question is, do we have any sense of whether we should be using ACE inhibitors, whether we should not be using ACE inhibitors? Where's the data on that, Dr. Wright? Do you know?
I think the data is where the data is on most of the other things. So one of the entry receptors for the SARS-CoV-2 virus is through the ACE2 receptor, and that's one of the receptors on the cells that allows the virus essentially to infiltrate the cell. It's not the only receptor, but it is something that has been shown as a way for the virus to actually enter the cell. And so there's been a lot of talk and conversation about whether ACE inhibitors and their mechanism of action, and if it potentially upregulates the ACE2 receptor, which could make you more susceptible to infection. Does it downregulate the ACE2 and upregulate the ACE1? Because ACE1 potentially can help decrease the action of ACE2. All very cellular microbiological changes that are a struggle to understand. Despite the years of education that I've gone through, I still have a hard time with it, as does the medical community and how that applies to this virus. So as of right now, and similarly, this is where some of the ibuprofen conversations is coming from in the sense of the ACE receptors and upregulation and downregulation, whether that makes people more susceptible or less susceptible to infection. Doesn't seem to right now change blood pressure in and of itself as far as being infected with the virus having an effect on blood pressure. And we are seeing patients that are hypotensive in the setting of respiratory failure leading to cardiopulmonary failure, or to cardiovascular failure, excuse me. But the other thing that we're seeing is a larger risk of severe disease and bad outcomes in patients that have underlying hypertension and cardiovascular disease, whether that's a mechanism of because of the ACE receptors and the ability for the virus to get in the cells, or whether it's a receptor for just underlying ability to mount a strong immune response, or whether there's a direct cardiotoxic and cardiovascular infection, still remains unclear. And at this point, we would say we recommend Tylenol over ibuprofen. We don't recommend that people stop their ACE inhibitors because having uncontrolled hypertension comes with its own set of problems, and we just don't have enough data to justify such a thing. And then we're ongoing studies as to ways that we can potentially manipulate the ACE receptors on the cells to try to block or attenuate the ability of the virus to enter the cells as far as treatment goes. And Danny, I don't know if you have anything else to add to that.
No, I agree. It feels like I'm back in medical school, and it's not a place I want to be. So thanks to the microbiologists who do this and to the molecular biologists who look at this stuff. I think that the takeaway from everyone here is if you're on an ACE or an ARB, an angiotensin receptor blocker, lisinopril, losartan, any of those medicines, I think the evidence says just continue taking it. If you're not on one of those, I think you don't need to start. We have time for a couple more questions. Can you talk about how the virus is mutating or changing over time?
So viruses typically over time do mutate, and we see the changes are micro changes again at the molecular level, where the virus tries to figure out if we figure out a way to block the virus at one place, the virus can potentially mutate and figure out a way to continue to infiltrate the cells, because that's how viruses continue to exist. And so there's certainly the benefit to them to be able to have ways to manipulate and change in order to continue to infect humans and animals, because that's how they continue to replicate and spread. We see that a lot with influenza when we think of the seasonal influenza, and that's why you have to get a flu shot every year, is because the influenza viruses are able to, there's a number of different strains, and they're also able to change and mutate, and we have to kind of revisit that seasonally. I think with the SARS-CoV-2, there certainly are very preliminary studies that have shown that it has the ability to do so, like most viruses do. It has the ability to change and mutate in order to perpetuate its own existence. We don't understand the details of how it's doing that yet. And additionally, we don't have the research for people that have been infected, that will allow us to track the specific molecular changes. But it is a virus that is proving that, just like most viruses, it absolutely has the ability to make those changes at the molecular level to continue to perpetuate its own existence, unfortunately.
Yeah, I'll add very quickly that it's really interesting. You can actually find sort of a family tree for this virus if you look up online. And what we know is that, as Dr. Wright said, there are typically small mutations in the RNA code of that virus that happen by chance, right? It's not a smart virus in that it tries to mutate. It literally just, when it replicates, sometimes has an error in the RNA code that it generates. And so every time there's an error that perpetuates forward, that's a mutation, right? And so they can actually look at the entire genome of this virus. It's big for a virus, but overall relatively small compared to our genome. And so they can actually look at the entire genetic code of this virus and look to see how it changes over time. And that's how they build a viral family tree. And so we know that the virus in Seattle looks slightly different from the virus in New York. And the virus in New York probably came from Europe as a sort of the intermediary step, because we can do that tracing of that viral RNA and look to see how it's changed over time. Dr. Wright, I'm going to take a quick one. It was a question about first responders donating blood or plasma and whether we're allowed to do it. I took a brief look at the children's website. They have a list of contraindications and reasons that you can't donate. Being a first responder is not listed as one of them. Being or feeling unwell is listed as one. So what I would say is, before you make a trip over to your blood donation center, and I would highly recommend you go and donate blood if you can, because there is a shortage always, and it's worsened during a time like this when people are afraid to go out. So if you're interested in donating blood, before you go and commit yourself and travel over there, just give the center a call, let them know what's going on, let them know who you are, and hopefully they're willing to accept the donation. But if not, then reach out to family and friends and see if they're willing to do it, because we definitely do need blood. We need platelets. It's chronically and consistently a problem, especially for our cancer patients, for other patients who are undergoing large surgeries. And we're not doing elective surgeries, but emergencies still come in, and we definitely still need those donations. So it's a great question, and I would say that there's no specific contraindication as far as I can tell, but definitely call over before you spend the time to go over and donate. Next question is, how are we handling contact tracing with EMS and fire partners? Dr. Wright, do you want to talk a little bit about what we're doing?
Yeah, so we're initially, when this wasn't as widespread as it is now, we were doing our best to try to circle back with all of our EMS partners and make sure that they knew when a positive patient came in. At this point, there are so many patients that we are seeing that are positive. It's very difficult to try to trace all of that back. I will say that we are working very closely with our nursing team and our physician team to make sure that if anybody comes in via EMS, potentially as like something totally unrelated, a trauma or something like that, and ends up being a COVID patient, we are working to make sure that we have ways to identify those patients and make sure that we're circling back to the crews. I've been very happy and comfortable to see the majority of our transports coming in via pre-hospital are coming in with EMS crews that are wearing N95s and eye protection and gowns, especially the ones that are suspected. And then we are working with our EPIC team to figure out ways that we can make sure patients that come in via EMS and are transported that do test positive, that there's a way that we can circle back. One of the most reliable ways, though, at this point, just because things are getting, the community spread is so wide, is that if your agency or you in particular are curious as to what the results were or what the outcomes were for your patients, reaching out to us as an EMS team, reaching out to Desmond, specifically Desmond McNeil, and saying and asking for follow-up, and that's one of the best ways too. But we are working with our system, with our EPIC team, our nurses and physicians to make sure that we're circling back for contact tracing for patients that are transported to the emergency department.
We're running low on time. I want to be respectful of everyone. We'll take just a couple more and then we'll get off and send a summary email with a link to the continuing education evaluation. The question is about whether there was concern that the virus has actually been in Colorado longer than we know, and that there was some degree of sort of unknown spread early on. And has UC Health and UCH seen more respiratory patients this season than past seasons?
I think that's definitely a question that's been out there. We did have a heavy respiratory season, and is this something that's been around, or this kind of prolonged respiratory infections and symptoms that we saw earlier on? But I will say that I think that it's unlikely, given the extreme peak and spike that we have seen in the last month and a half. I think that if this were something that were present in the community earlier on, now an isolated case here and there maybe, but as we have learned, the number of patients that get infected by a patient that has coronavirus or COVID-19 is 3 to 4, which means every patient that is positive for coronavirus ends up infecting another 3 to 4 patients, which is what gives us this big exponential spread and increase. And I think that if it were here earlier, we would have seen an overwhelming influx of patients with a big ARDS and ventilators, et cetera. Right now we have 200 and some patients admitted to the university system, and 100 of those patients are on ventilators. So while we certainly had a heavier respiratory season than usual, we did not see that amount of critically ill patients, which I think would indicate that it came maybe a little bit earlier, but pretty much we're accurate on tracking when that made it over here to Colorado.
I'll take one brief one and then one slightly longer one, and that's, I think, almost at the end. So there was a question of whether iodine added to drinks or food would kill the virus. There's no evidence, as far as I can tell, again, doing a quick literature search, that taking elemental iodine and putting it into drinks or anything has direct virucidal activity. We know that the povidone iodine solution that we put on the skin does have activity against bacteria and viruses, but that's very different than taking additional elemental iodine. So I can't recommend adding that to your drinks or food as of right now. And then the other question was whether there's a shortage of PPE here in Colorado and what we're going to expect in the future. And that was definitely a concern as this was ramping up, whether we would have enough PPE for our first responders, for our in-hospital providers. What I can say is that we are obviously not as hard hit as some other areas of the country, and a lot of hospital systems did well to stockpile early. I can say that for EMS agencies, it has been more of a hit or miss, again, from anecdotal evidence after discussions with other medical directors, other EMS agencies. There are definitely some agencies that are out of specific components of PPE, whether it's gowns, whether it's N95 masks. And so people have, in some instances, have resorted to either using PPE for just, high-risk patients, or using just surgical gowns, or using things like Tyvek gowns rather than the blue or sort of yellow gowns that you typically see in the hospital. I can't say that there's a large-scale, widespread PPE shortage across hospital systems. Certainly at UC Health, we are currently adequately prepared for things, but certainly within some EMS agencies, there has been difficulty procuring, especially as state stockpiles have dwindled, and as some purchasing agencies or places to purchase from have only been selling to healthcare agencies. It's been challenging for EMS in some instances to acquire PPE. If your agency is low or out, what I would recommend is that you reach out to your county leadership, to your county health department, and then there are other alternative ways to reach out to the state as well, through your health departments or through your North Central region healthcare coalition, or the other healthcare coalitions if you're outside of the Denver metro region. If you're low or out of PPE stocks, that's probably the first place to go to ask for that equipment. And hopefully, as we've seen, the curve has been flattened, and so we will be able to re-up on PPE better than we have been in the past, especially as things in New York and New Jersey continue to trend down in terms of number of cases, and as production and supply side improves, as different companies are increasing production of masks, gowns, and other essential pieces of PPE. Mark, I don't know if you or Angie want to speak to it in any more detail.
I think you covered it. Thank you.
Yep, agreed. All right. How'd we do on the questions? Danny, are we anything else lingering out there?
It looks like we've knocked them all out. I don't know if, Mark, you saw any that I missed.
I think we've got them all either directly or indirectly.
Okay. Well, thank you again, all of you, for joining us. I hope this is helpful. I hope we're able to provide you with some information that's constantly changing, but my hope is to reach out and provide you guys with what we know and kind of what we're trying to do in the setting of this pandemic. Please let Desmond know, or myself, Dr. Wilner, or Mark, if you have anything in particular, lingering questions, anything else you want to know about, anything else you want us to focus on. And if you guys think this is helpful, we'll continue to try to do this as a update for our EMS community. And again, thank you. We really appreciate everything you guys do each and every day.
Thanks, everybody.